between you all and lunch. So um, I'll try to bear that in mind as we go along. I'm Brad Dixon. I'm a pediatric nephrologist at the University of Colorado and Children's Hospital Colorado. And for this next talk, we'll be focusing on some new treatments. You've heard from Dr. Sridharan and Dr. Cole some of the relationships of the current treatments like eculizumab and ravulizumab for complement-mediated TMA or AHUS, and we'll sort of peek behind the curtain at what might be coming down the pipeline for patients with these conditions. So these are my disclosures. I do serve as a consultant and get research funding for different complement-mediated diseases. So when we talk about new treatments or what is going to be coming available, it's hard to make sense of what's in the future if we don't really understand what's in the past. And prior to 2011, there were no definitive therapies for AHUS. So we're really only talking about the last 15 years where there have been effective therapies for this condition. And what we had before 2011 was plasmapheresis, and it was widely used for patients with CMTMA or AHUS without very good evidence in the literature that it was effective. There's certainly anecdotal reports of people getting better with plasmapheresis, but there's no definitive literature to support it. And that all changed with the availability of eculizumab, or Soliris is the brand name for that, and that was approved for AHUS in 2011. And that was a game changer for patients with this condition. And building on the success of eculizumab, ravulizumab, the longer-acting cousin or derivative of eculizumab, became available for AHUS in 2019. So again, changing the game for patients with AHUS. So we know that these medications, eculizumab and ravulizumab, are exceptionally effective at treating the disease and have helped many, many people. So they've been life-changing. But they do still have some drawbacks. So one major drawback is the route of administration. Eculizumab and ravulizumab are both IV medications, so they require either an infusion center to administer the medicine or sometimes a home health nurse to administer the medicine. And for me as a pediatrician, because my patients often have a lot of trauma to their blood vessels with repeated IVs. Sometimes they require infusion ports to be able to receive the medication regularly. At least with eculizumab, the infusion frequency in an adult is every 2 weeks. And even though it's been amazingly beneficial to patients with AHUS, that frequency can be intrusive to the work work schedule, home schedule, school schedule, vacations. This certainly got better with ravulizumab. So for an adult patient or a pediatric patient over 44 pounds, the medication can be given every 8 weeks. And so that was very freeing for patients who didn't need IV treatments every 2 weeks. Certainly, the major risk that comes with eculizumab and ravulizumab is the risk of infection. Dr. Cole shared with you in the last talk that the complement system is very important at protecting us from infection. And there's a specific bacteria called Neisseria. It's a bacteria that causes meningitis or severe bloodstream infections in patients. And the complement system is important at protecting us from lots of infections, but it's especially important in protecting us against this bacteria called Neisseria. And lastly, because these medications are quite costly, it has limited access to eculizumab and ravulizumab in many parts of the world. So, in some parts of the world, these medicines still aren't available for patients because of the restrictive nature of the health authority of that particular country or that particular part of the world. So, to address these drawbacks, to build on success, if you will, while still getting good control of the disease as we get with eculizumab and ravulizumab, there are some new therapies that are becoming available or that are under investigation for the treatment of AHUS. And these new therapies are either improving on the route of administration, so they may be given in a different manner than um, through a vein. They might be given under the skin or given orally. The frequency of administration may be an improvement. And ultimately, there may be improvements in cost, and that could, in turn, improve the access to this medication across the world. So, what would an ideal future therapy look like for AHUS? Just to speak very broadly, very generically about what an ideal therapy for any condition might look like. So, it needs to be given conveniently. So, uh, an oral therapy, an oral medication, or a medication given by a patient themselves under the skin might be superior to an IV treatment in that way. The medication obviously still has to be effective at controlling the disease. So it doesn't do us any good to have a more convenient treatment if it doesn't work. It should have minimal side effects. So we shouldn't be giving up the burden of the medicine to prevent the burden of the disease. Obviously, it needs to be approved by health authorities like the FDA, so it has to be available for a doctor to prescribe. And it should be widely available, so patients should have access to it, ideally all over the world, and at as low a cost as possible to minimize the burden on the healthcare system as a whole. So I want to start by talking about what eculizumab and ravulizumab are. And they're in a class of medicines that we call biologic medications. So eculizumab and ravulizumab are members of a class of molecules called monoclonal antibodies. And what monoclonal antibodies means is that these are antibodies that come from living cells in the laboratory. So they're living cells grown in a culture dish, if you will, where the antibody molecules produced by those cells are identical to another. So it's an antibody that will be the same as it's manufactured. In every vial of that medicine, it'll be basically the same. Because these medications are made by living cells, they're not made by a chemical process. And these could be animal cells, they could be plant cells, they could be bacteria or yeast. That puts them in this class of medicines called biologic medications or biologics, meaning they're made by living things. So any biologic medication, and that includes hormones like insulin. So insulin is probably one of the first biologic medications that were made available to patients. Protein hormones like growth hormone, or antibodies like eculizumab. And there are many, many antibodies that fall into this same class of antibodies used for medicinal purposes, are unique to the cells that make them. So there is a particular cell that is used to make eculizumab or ravulizumab because of the programming of that cell to make it. So, to help increase access to biologic medications, because those can be very costly, um, biosimilars might be produced. So, what is a biosimilar? A biosimilar is a biologic medication that's very close to, very similar to, but has, at least as defined by the Food and Drug Administration, no clinically meaningful difference from an existing approved biologic. And what we call that is the reference product. Um, so biosimilars, um, you can think of them very broadly or loosely as like generic medications, but there's an important difference between a biosimilar and a generic medication, like, for example, acetaminophen that you might get at Walgreens versus Tylenol, brand name Tylenol. So these are different because the ingredients of a generic medication, like the example that I gave you between acetaminophen and brand name Tylenol, are identical. The chemical processes used to make that generic medication and the chemical processes used to make Tylenol are the same. So when you pick up a bottle of generic Tylenol at your pharmacy or grocery store, it'll have the exact same ingredients as Tylenol. But there are very minor differences between a biologic, a reference product, um, and a biosimilar because they're made by living cells. So, living cells that are making these medications, making these antibodies, may have very, very subtle differences. So, biologic medications, in contrast to a small molecule, a medicine like acetaminophen, are typically much more costly to make and purify because they're complex molecules. They're antibodies rather than these small chemicals, and they're made by living cells. So, um, it takes a lot of work to make a biologic that we don't necessarily have to go through to make a small molecule. And because biologics take a lot of work and they take a lot of investigation to make sure that they're safe, they typically cost significantly more than a small molecule. So, because biologics, the ability and process to make them became more widespread, there are many, many more biologics to treat many different diseases that are available. And this helped to add to the healthcare costs of the United States and many other countries where biologics are available. And this growing healthcare burden, this financial burden on our healthcare system as a whole, led Congress to pass some legislation about 15 years ago called the Biologics Price Competition and Innovation Act, or BPCIA. And what this created was, and this is exact wording from the FDA's website, is an abbreviated approval process. This abbreviated approval process helps to move faster and in a less costly manner the development of biologic medications as biosimilars, and in theory, without reducing the safety or the effectiveness of that biosimilar. So biosimilars might cost less money than the reference product or the original product because um, manufacturers may rely on all of the studies that were done for that reference product to show that it was safe and effective without having to conduct the same clinical trials themselves. So what often um, add to the cost of developing a biologic medication is the clinical trials, the patients receiving that medication and being studied very carefully to make sure that that medicine is safe and effective. And so, if a biosimilar medicine is very, very, very close to the reference product, there is an assumption that it's as safe and effective as the reference product. And ultimately, that lower cost is can be passed on to insurance companies. So, an insurance company may, on their formulary, their list of drugs that they prefer or approve, may use a biosimilar because it's going to be less costly. So, federal regulatory agencies, and in this case, what I mean in the United States is the FDA, but there are similar agencies in Europe, Japan, other parts of the world, do have a burden to prove that biosimilars are as safe and effective as the original product by reviewing the data and studies from a manufacturer that's making that biosimilar, by monitoring for any evidence that the biosimilar medication is in any way not safe or effective after approval, inspecting the manufacturing facilities to make sure that those are being produced in a safe manner, and receiving patient safety reports of an unexpected event made to the FDA. And I think this last point is really important, as we'll kind of get into in the next few slides. Biosimilar use in AHUS. If there are patients that have an adverse event related to a biosimilar, it's very important for the FDA to learn about those things. So there are some biosimilars that can get an added distinction, and that distinction is by being called an interchangeable biosimilar. What does that mean? Some biosimilars will need to go through an extra process, some extra investigation to determine if they can be substituted safely and effectively for the reference product. And if the FDA, using that label, says it's safely and effectively substitutable for the reference product, we call that an interchangeable biosimilar. So typically, what is involved in determining if a medication is interchangeable is a crossover study. And a crossover study is where patients are on one medicine and they switch to the other medicine. They're on the reference product and they switch to the biosimilar, or vice versa. They're on the biosimilar and they switch to the reference product. Um, and there is no detectable change in the control of their disease, no detectable difference in their efficacy, and there's no difference in safety. There's no difference in the number of adverse events, the number of things that happen in a negative way when you're on one or the other. So once a medication is determined to be interchangeable by the FDA, they can be substituted by the dispensing pharmacy, and that's potentially without the prescribing physician or the patient being notified. So this is different from state to state. If you look on different websites, it will tell you what each state's reporting requirements are. In some states, the patient has to be notified, but the physician does not. In other states, the physician has to be notified, but the patient does not. And this substitution by the pharmacy is what we call pharmacy level substitution. So it means that it can be done without being directed to the pharmacy, being directed to make that change. Another important point that I want to make is that biosimilars may or may not be studied for the disease in question to be approved for that indication. So this is actually a really important point for this community, especially. So the approval of a biosimilar medication by the FDA will be dependent on the data that the FDA is looking at to say it's safe and effective in an appropriate condition of use. However, the FDA may approve a biosimilar for diseases or populations without directly studying the medicine in that disease or population if a manufacturer can provide enough justification to do so. So if the FDA says, well, we know that, for example, eculizumab is safe and effective in AHUS, so a biosimilar to eculizumab is likely to be safe and effective in AHUS as well. And knowing if eculizumab works in a particular condition, we know that and we know that complement, which is what eculizumab targets, is important in a disease, then the biosimilar may work in that same way. So there are two biosimilars on the market currently. There's one called eculizumab or Epesquili. So this is a drug that's and it's an interchangeable biosimilar. It's an anti-C5 antibody like eculizumab, and in fact, it's eculizumab at least in similarity. It's made by Teva and Samsung, And it has the same dosing regimen as you would find with the reference product, which is Soliris. It has the same what we call black box warning, so it has the same risk for the bacteria called Neisseria that can cause meningitis or severe bloodstream infections. Um, and so it has the same warning label for that medication. Um, Episquili was studied in a different disease, in PNH, which is a blood disorder that many of you may have heard of. That in a crossover study, it showed that the biosimilar was as safe and as effective in treating PNH. And this was published a few years ago in a medical journal. But based on that and based on additional safety data, the FDA approved this medication for PNH and AHUS in 2024. So this medication is currently approved for AHUS, even though to date there have not been any studies directly looking at this drug in AHUS. The same story is another eculizumab biosimilar, Bikemv. This drug is made by Amgen. It's also an anti-C5 antibody. Has the same dosing regimen as eculizumab because of its biosimilar nature. Same black box warning for Neisseria infections. This Bikemv was also studied in PNH in the same type of study where we cross over a patient from eculizumab to the biosimilar or vice versa. This drug was shown to have similar effectiveness and similar safety compared to eculizumab in PNH, and that was also published. Similar to Episquili, without being directly studied in AHUS, Bikemv was approved by the FDA last year for PNH and AHUS. So, focusing on our ideal future therapies is Episquili. I'm probably not even saying that right, but that's how I'll say it. Is Episquili and Bikemv convenient? It's still IV like Soliris, so and it's still more frequent than ravulizumab. It's essentially the same dosing frequency as the OG Soliris. Is it effective at controlling the disease? Well, it seems to be from PNH studies, but it's not been studied directly in AHUS. Does it have minimal side effects? It has similar risks compared to eculizumab and ravulizumab of infection. It is currently approved by the FDA. Is it widely available and is it low cost? So these numbers that I'm going to show you are what we call wholesale acquisition cost. That means what does a distributor of a medication need to pay for a medication? So this is not the cost that a patient might see or an out-of-pocket cost for a patient. But just to be able to compare apples to apples, that's why I'm showing you this figure. So Bikemv and Episquili are modestly less expensive when we compare it to Soliris for a 1-month supply. So in addition to medications targeting the C5 protein, we're also now exploring some medications that target other parts of the pathway. And there are a number of complement targeted agents that are in red here that are approved for use in different conditions in the United States. And there are many more that I have here in orange that are still in development, still being explored in different complement-mediated conditions. And in the next few slides, I'll be focusing on a couple drugs, a couple medications that are being explored specifically in AHUS. So the first medication that's still under development, still being explored, is a medication called crovalimab. It is an anti-C5 antibody, so it's similar in that way to eculizumab, ravulizumab, the biosimilars. But it's been uh, it's been engineered like ravulizumab to recycle into the bloodstream. So it has a longer half-life um, uh, than eculizumab itself. It also targets a different part of the C5 protein. So it sticks to a different part of the C5 protein than eculizumab and ravulizumab. And there are some patients in different parts of the world that have genetic differences in their C5 protein where eculizumab doesn't bind well and doesn't work well. And crovalimab overcomes that by binding to a different part of the C5 protein. Crovalimab is also more soluble, meaning it stays in solution at high concentrations than eculizumab and ravulizumab. And so you can put more drug in a smaller volume, a smaller amount of liquid. And that ultimately means it can be given safely and relatively comfortably under the skin. And that ultimately means that there's a possibility of self administration. A patient could give the medication to themselves at home. Um, and especially for me as a pediatrician, it may mean that a patient no longer needs an infusion port to receive their treatments. They may be able to receive it under the skin. Crovalimab has been studied and found to be safe and effective in PNH and that other blood disorder that I mentioned earlier. There was a study called the Composer study where they looked at um, about 10 patients who hadn't received any complement targeted medication and 19 patients who had previously been treated with eculizumab. And they found that in the what we call treatment naive patients, patients that hadn't seen a complement inhibitor before, they had improvement in their disease control, just like someone who might receive eculizumab. And in the patients who were previously treated with eculizumab or switched from eculizumab, there was no difference in their disease control. And it seemed to have a similar safety profile when we compare it to eculizumab and ravulizumab. So there have been some other studies, the Commodore 1, 2, and 3 study, and the Commodore 3 study also showed adequate efficacy and safety um, uh, in this patient population in PNH. So is this a convenient medication? Relatively, yes. There's certainly the discomfort and the nuisance of a under the skin medication, but it may represent an advance in that convenience. Is it effective in controlling the disease? Perhaps. We think it is in PNH. There are still studies investigating that medication in AHOS. In Colorado, we're one of the sites for these studies investigating crovalimab in children and adults with AHOS. Does it have minimal side effects? Similar side effects, similar infection risks to eculizumab and ravulizumab. I'll specifically mention that in patients switching from crovalimab to from eculizumab or ravulizumab to crovalimab, because the antibodies bind in different spots on the C5 protein, there is a specific condition or side effect that can happen called serum sickness, where if you have two different antibodies stuck to the same protein, it can activate the complement system. So we really primarily see that serum sickness, that problem in patients switching from one to the other, not necessarily someone starting the crovalimab brand new. Is it commercially approved? Yes, it's currently approved in the US by the FDA for PNH, not yet for AHUS. Is it widely available and is it low cost? It's when you look at the wholesale acquisition cost, this was from drugs.com, it's about the same cost as the biosimilar. So I wouldn't necessarily say that this is low cost. So then, question? Okay, very good. So the other treatment that I wanted to talk about today is iptacopan. So iptacopan is an oral small molecule, and this is a picture of the chemical structure of iptacopan here. So it's a chemical rather than an antibody that inhibits a part of the complement system that Dr. Cole already pointed out to you, the alternative pathway or the amplification loop. And so it targets in a different part of the complement system than the other medications that I've showed you. It targets what I would say is upstream, meaning higher in the pathway than C5, where eculizumab, ravulizumab, and crovalimab target. A standard adult dose of iptacopan is 200 milligrams by mouth twice a day. And at least theoretically, if you target upstream, there is a different risk of infection than we see with C5 inhibitors like eculizumab. So there are other families of bacteria that the more upstream part of the complement system helps to protect us against. And so there's theoretically a greater risk of infections from these other families of bacteria called encapsulated organisms than we might see with a C5 inhibitor like eculizumab. Like every other medication I've talked about this morning, the efficacy and safety of iptacopan was first shown in PNH. Um, This was in two different phase 3 studies. One was the APPLY study, where patients who were on eculizumab were switched to iptacopan or continued on eculizumab. And then the APPOINT study, where patients were naive. They hadn't been treated with any complement inhibitor and started on iptacopan. And the vast majority of patients in both of these studies were found to meet the primary endpoint of effectiveness in controlling the disease, and the safety data was reassuring. And this led the FDA to approve iptacopan in the treatment of PNH in 2023. Um, because I'm a nephrologist, I also have to at least mention a complement-mediated kidney disease called C3 glomerulopathy, another passion of mine. And there was a study looking at the effectiveness of iptacopan targeting this complement-mediated kidney disease, either in patients who had had a kidney transplant or patients who had the kidney disease in their native kidney, the kidneys they were born with. And in patients who had C3 glomerulopathy that affected the kidneys they were born with, their native kidneys, there was a 45% improvement in the protein in the urine that we can see with this disease. And when patients who had a kidney transplant were treated with this medication, biopsies showed that complement staining of their transplanted kidney, the complement activation that's happening in this condition was significantly improved as well. So some promise in this disease. So how about iptacopan? Is this the ideal future therapy? Is it a convenient means of administration? Yes. I think oral medication is probably what most people would say is the most convenient way to receive a treatment. Is it effective in controlling the disease? We maybe from what we know from PNH and C3G, it seems to be a good treatment, but it's still being studied in AHUS, so we still don't know. Are there minimal side effects? Too early to tell. I think the infection risks may be similar to eculizumab. There may be greater infection risks because it targets a different part of the complement system. Is it commercially approved? Yes, there are now 3 different indications: PNH, which is the blood disorder, and 2 different kidney diseases, IgA nephropathy and C3 glomerulopathy, that this drug has been approved for, not yet approved for AHUS. Is it widely available and low cost? Unfortunately, it's not widely available and is not going to be the not going to alleviate the financial burden of treatment that we currently experience with other medications. So I didn't talk a lot about these drugs, these newer therapies in AHUS because we're still studying them. So there are still ongoing trials. There are 2 studies exploring crovalimab in adults and pediatric patients. There are 2 studies of iptacopan in AHUS. One is in patients who are started on iptacopan when they first present with AHUS or present with a relapse in their AHUS, and the Appreciate study where patients who are on C5 inhibition can switch to iptacopan. And in trolling clinicaltrials.gov, there's also a trial that's looking at an antibody that targets the alternative pathway that's being explored as well. So that's all I have, and happy to take questions. Yes. Yeah. Yes. So narsoplimab, or OMS 721, is a drug that, here, I'll see if I can go back to my diagram here. So narsoplimab actually targets up here at this part of the complement system. It targets the lectin pathway. So narsoplimab has been studied in a number of different conditions. It's shown some benefit, at least in clinical trials, in a form of TMA that happens after a bone marrow transplant. So there is some evidence that it helps patients with that form of TMA. I'm not sure if it's being studied in AHUS specifically. It's been studied in other diseases like IgA nephropathy. So it's as a complement inhibitor and targeting a very specific part of the complement system, it's being explored. I'm just not sure if it's being studied in AHUS specifically. Yes. It's a great question. So I think one, and I'm not a hematologist, and so I may rely on my hematology colleagues in the room here to correct me or throw tomatoes at me. But I think PNH is a little bit more of a straightforward disease to study because you're really looking for one clinical problem, and that is the breakdown of red blood cells that are being destroyed by complement. So it's if I can use the word readout, the readout of the study is relatively simple. Are patients getting blood transfusions because they're breaking down red blood cells? Or are they getting less blood transfusions? Can you measure their LDH? Can you measure the blood tests that say we've slowed down or stopped the breakdown of red blood cells? AHUS is a little bit more complicated because it can affect lots of different organs in the body and the kidneys as well. So sometimes it's harder to show it's effective in AHUS because it affects lots of different organ systems in the body. That would be my answer. Dr. Brodsky?
Yeah, no, I think you've answered it well. And I think you've been great. The other reason is that there is a diagnostic test.
Right.
Whereas even though HUS is often around, not recognized, and it's been known as a complement disease for much longer. I would suggest, under your ideal future therapies, adding a couple bolts.
Sure.
Treated hundreds of PNH patients and used all of these agents. And that would be long half-life. And that would be ability to monitor activity of the drug. I'll give you an example just from personal experience. So you can have patients that are on these short-acting iptacopan-like drugs who go into a Taco Bell and get food poisoning. And they're throwing up. They got a complement amplifying condition. And they can't take their meds. Had someone get norovirus on the cruise ship. I've had someone forget their drugs. So these and lead to really serious breakthrough hemolysis. So half-life is very important. The other thing from a physician standpoint is that you get patients coming in who are breaking through. So why? Are they breaking through the drug or are they not taking the drug? I've seen both of those scenarios too. And you can't tell if you don't have a way to monitor. And the other thing I would say is I've stopped, and many of us have stopped referring to these as upstream inhibitors because they are only upstream in the alternative pathway. they are not even in the pathway, in the classical pathway or molecular pathway. And if you have a classical pathway stimulant, PAH or atypical and you're only on an alternative pathway inhibitor, at low rate, it's like no drugs then. So those are some of the other things I would consider.
Depending on how,
drugs,
sure.
but I would put them in the ideal category. I would add longer half-life. That's what worries me about this.
Okay.
I've seen some danger.
Sure. Thank you. Other questions? Anybody hungry for lunch? Okay. Thank you very much.